The topic of our lecture today is talking about the treatment or the drug therapy of gout. So, to start up with, let's review some information about gout. Gout is a form of complex arthritis. It is characterized by sudden, severe attacks of pain, swelling in the joints, redness, and tenderness. It could happen to one or more joints. Usually, one of the joints that is inflamed or having this reaction with gout is the big toe. Now, an attack of gout can happen suddenly. Maybe when somebody's sleeping in the middle of the night, he would feel that the big toe is on fire. The affected joint will be hot, swollen, and painful. And these are usually happening because of an inflammatory reaction that's occurring at that site. So we can summarize that gout is an inflammatory disease. But what is the cause of gout? Actually, gout can be also considered as a metabolic disease. It happens because we have inflammation or what we called arthritis. This is because of deposition of monosodium urate crystals. It can deposit in the joints, as we said, but also in other places such as the cartilage. Additionally, we can see some of these deposits of uric acid in the kidneys. So we can have renal caliculi. Also, we can have intestinal nephritis as well. Now, the characteristics of the inflammation of the joint on gout, or what we call gouty arthritis, is that it is of sudden onset. So, as we said, it can start in the middle of the night. It usually affects males and more commonly in middle-aged males. It's characterized by severe pain in the distal joints. As we said, it can be in the toes. It is an intense inflammation. The episodes can recur at any time. It is influenced by diet, and these changes on the bone can be identified by X-ray. So how does gout start, or what is the cascade of event that leads to this inflammation? We said we have usually high levels of serum uric acid, which we characterize as, or which we call as hyperuricemia. So uric acid is a poorly soluble substance that is the major end product of purine metabolism. Now, many of the mammals, they have an enzyme called uricase, and uricase usually converts uric acid to more soluble allantoin. Unfortunately, humans do not possess this enzyme. Again, the enzyme name is uricase. So, we have to control the levels of uric acid through its excretion from the kidneys. So, in any instant where we have an imbalance between the uptake and the elimination or excretion of uric acid, we might have elevated levels of uric acid in the serum, leading to deposition of the substance, as we said, in joints, in the kidneys, in the intestine, sometimes in cartilages as well. So these urate crystals will bind to certain protein and receptors in the surface of the cells that are lining the joints, which we call synoviocytes. Synoviocytes will then engulf these urate crystals. This will lead to release of many cytokines, prostaglandins, lysosomal enzymes, and interleukin-1. So this cytokine release will cause attraction of a number of cells. From these cells, we have polymorph nuclear leukocytes. These cells will migrate into the joint space and amplify the ongoing inflammatory process. The polymorph nuclear leukocytes is a critical component of crystal-induced inflammation. So, again, let's revise some of the information we have learned. One of the important characteristics of acute gouty arthritis is that it can happen at any time, so it's a sudden onset. We said it's mainly happening in males, middle-aged male, is characterized by severe pain. This is because of the cytokine release, especially interleukin 1 and prostaglandins. We said it's happening mainly in the distal joints, although it can happen in other places. It is associated with intense inflammation that keeps propagated with the presence or the chemotactic of the different cells, mainly polymorph nuclear leukocytes. Now, at later stages of the attack, there is an increased number of these mononuclear phagocytes or macrophages. They will start ingesting the urate crystal and they will release more inflammatory mediator. So, how can we diagnose acute gouty arthritis? We said we can see the bony erosions on the x-ray, but also it is characterized by hyperuricemia. Now, one note here, it is influenced by diet, and this is very important. How is so? Note, there are two reasons for hyperuricemia happening. The first one is when the production of uric acid exceeds the excretion of uric acid. The other is when the excretion or the net uric acid loss results when excretion exceeds production. So we usually have to have a balance. So either if we intake too much substances that gets converted in our body to uric acid. So what kind of substances are we talking about? Usually meat, red meats. Red meats will get digested in our body. They will produce purine. Purine will get metabolized to uric acid. So if people who have the problem of gout ingest too much red meat or proteins, usually they will end up with hyperuricemia. The other thing, which is we're talking about here, is where we have imbalance between the excretion part. So if the kidney does not excrete enough uric acid, this will lead to buildup of uric acid in the bloodstream. Again, we will have hyperuricemia. While we talked about some of the characteristics of gout, let's remember that not only gout presents as arthritis, but it also can present at other forms such as chronic tophaceous gout. So tophus means localized deposits of monosodium urate crystals. So tophaceous gout is a chronic form of gout where we see nodular masses, so in the nodes of uric acid crystals that are deposited in different tissues areas of the body. Usually these tophi are present as hard nodules, most commonly around the fingers, as we can see in this picture. And this not only is painful inflammatory process, but also disfigurating for the patient. So we said these tophi can be present in the toes, in the fingers, in the elbows. Here also we can see a classic location of the tophi on the helix of the ear. Additionally, we talked about the changes that can be detected in the X-ray. So you can note in the distal interphalangeal joint, we can see that there is joint destruction, and we can see that there are the formation of cysts in the bone. Additionally, here we can see bony erosions in the joints. So these are some of the the clinical manifestations of gout in the body. Again, let's not forget it can also happen in other areas of the body. We said we have uric acid renal caliculi, which means stones in the kidneys. One important note I need to mention is while clinical gouty episodes are usually associated with hyperuricemia, most individuals with hyperuricemia may never develop a clinical event from these urate crystal deposition. So before starting the chronic urate lowering therapy for gout patient, where hyperuricemia is associated with gout and also with the position of urate stones, we need to distinguish which individuals have only hyperuricemia, which individuals have gouty episodes resulting from that hyperuricemia. Because usually the efficacy of long-term drug treatment of asymptomatic, that means hyperuricemia without symptoms, is not proven to be effective. So even in some individuals where we can see high levels of uric acid, maybe they would go throughout their whole life without having adverse consequences. So what are the cardinal manifestations that make a person characterized of gout and needing of pharmacological treatment? The first one is the presence of arthritis. So we have inflammation in this case. Also, we have tophi. We can also have nephrolithiasis, and this is the kidney stones, or it can end up resulting in nephropathy. Now, arthritis can be either acute or chronic, and the treatment we're going to mention for both chronic and acute gouty arthritis. All of these are associated with increased levels of uric acid in the bloodstream, which we call hyperuricemia. We said the diet is a major influence on levels of uric acid, which will ultimately affect the condition of gout. So, if we have a high dietary intake of protein, this will be metabolized in our body to purine bases. Also, when the cells in our body metabolize or break down, we're also going to have increase in purine bases. This will result in the formation of hypoxanthine. Hypoxanthine will be converted to xanthine by an enzyme called xanthine oxidase. Also, this enzyme again, xanthine oxidase, will convert xanthine into uric acid. Now, in the kidneys, how is uric acid handled? What's very important to remember is that the net effect of all the different events that happen throughout the kidney glomeruli is net excretion of uric acid. So we start up with glomerular filtration. This will lead to decrease the concentration of uric acid in the plasma. Later on, at the proximal convoluted tubule, we have reabsorption. Later on, a stage of tubular excretion. And then finally, we have some post-secretory reabsorption. But ultimately, the total or the net effect is excretion of uric acid. So if we want to control this process, we can prevent the process of tubular reabsorption or the post-secretory reabsorption by the use of certain pharmacological agents that we're going to mention in a bit. So to summarize, the problems associated with gout is that we have excessive total body levels of uric acid, leading to deposition of monosodium urate crystals in the joints and the other tissue. This crystal will cause induction of inflammation. So we're going to start talking about the treatment of gout, and we'll start with the treatment of acute gouty arthritis. So the drugs that are used to treat this condition. We'll start with colchicine. Even though Colchicine is not the first-line drug therapy for acute gout arthritis, but colchicine was the primary treatment for many years. No other drugs that can be used, we have steroids, and then we have non-steroidal anti-inflammatory drugs. Additionally, we can use some urate-lowering drugs. These include allopurinol, probenecid, or febuxostat. In addition to all of the drug treatments in the condition of acute gouty arthritis, we need to have bed rest, analgesia, pain relief, and time will help in resolving this problem. So let's start with the non-steroidal anti-inflammatory drugs. We have examples here. We have indomethacin, naproxen, ibuprofen, sulindac, and ketoprofen. Remember that all of these share a common mechanism of action, which is inhibition of the synthesis of prostaglandin by inhibition of the enzyme cyclooxygenase. In addition to that, indomethacin can inhibit urate crystal phagocytosis. In addition, most of the other NSAIDs that we mentioned also have this property, except for one drug, which is aspirin. Aspirin actually is not used in the treatment of acute gouty arthritis because it can cause renal retention of uric acid when used at low doses, and this is lower than 2.6 grams per day. Actually, on the other hand, at high doses, it is uricosuric, but these are doses higher than 3.6 grams per day. So, what do we use? Usually, indomethacin is commonly used in the initial treatment of gout as a replacement for colchicine. How do we administer it? We can use 25 to 50 milligram up to 4 times a day. And this is usually for 5 to 7 days. The second drug we're going to talk about is colchicine. Colchicine is a plant alkaloid. It comes from a plant called Colchicum autumnale. It has other names, the autumn crocus or meadow saffron. When do we use colchicine? Mainly, it is effective in gouty arthritis. It does not have the property of being an analgesic. So remember, NSAIDs, in addition to their anti-inflammatory effect, they're also painkillers, so they have the property of analgesia. On the other hand, colchicine is not an analgesic. It does not have any effect on renal excretion of uric acid. It does not alter the plasma solubility of uric acid, so it neither raises nor lowers the serum uric acid. So how does colchicine help in the treatment of gouty arthritis? It does so by inhibition of microtubule polymerization. So it binds to tubulin, which is one of the main constituents of microtubule, and prevents the polymerization of these subunits of tubulin to form the microtubule. Remember, we said the phagocytosis is a major part of the inflammatory process associated with gout or gouty arthritis. So, for the cells to engulf these urate crystals, for them to move around and to be able to perform the process of phagocytosis, they need to have continuous formation and polymerization of microtubule. Thus, if we inhibit the microtubule polymerization, we will inhibit this process or the activation of phagocytes. Thus, we will reduce inflammatory response to these deposited crystals. Additionally, we can diminish the polymorph nuclear leukocytes phagocytosis of crystals, and this will block the cellular response to deposited crystal, blocking the inflammation, blocking the cytokine release, thus help in reductions of the signs and symptoms of inflammatory arthritis associated with gout. Where does colchicine take action? It prevents the synoviocytes from engulfing the crystal urate crystals, preventing cytokines release, preventing the influx of PMNs, and again, preventing the cascade of events that lead to the propagation of inflammation. So colchicine can be used either at a high dose or a low dose. For the treatment of acute gouty arthritis, we usually use a high dose. For the prevention of recurrent gouty arthritis, we use a low dose. So this is maintenance therapy to prevent further flare-ups or attacks of gout. Side effects or toxicity that's associated with colchicine. It can cause some gastrointestinal problems such as nausea, vomiting, cramping, diarrhea, abdominal pain. It can cause some hematological problems such as agranulocytosis, aplastic anemia, and thrombocytopenia. Remember, we said colchicine prevent the polymerization of microtubules. And remember, microtubules are very important for the formation of the mitotic spindle. So in highly replicating cells, colchicine can affect the replication process of these cells. That's why it would affect the blood forming cells such as platelets, red blood cells, and also white blood cells. So we have to be careful about the use of colchicine because of these adverse effects. Additionally, colchicine might cause muscular weakness. These adverse effects are dose related and they are more common when the patient have a renal or hepatic disease. So it's better to use it for daily prophylaxis because we use a low dose. It prevents the recurrence of attack. Usually colchicine can be used at a concentration of 0.6 milligram 2 times a day. Now we note that recently we've seen a decline in its use in acute gouty arthritis, which is the high dose that we mentioned, and it's more replaced now by non-steroidal anti-inflammatory drugs as the first-line drugs for those acute conditions. Remember, we said the predisposing cause of gout is high levels of uric acid or hyperuricemia. So this is either happening because we have an excessive production of uric acid or we have inadequate excretion. So one way to address this problem is either by blocking the production or by enhancing the excretion. The net effect would be net reduction in total body pool of uric acid. So we have certain drugs that we call urate lowering drugs. These help in the prevention of arthritis, tophi, and stones by lowering total body pool of uric acid. So they are not indicated immediately after the first attack. Actually, they might worsen the attack if they're used after the first attack, so we have to wait some time before administering these drugs. This is because when we use these urate lowering drugs, this would result in urate crystal being shed from the cartilages, from the joints into the joint space, and this can result in flare-up of acute inflammation. So their use after an attack immediately can cause worsening or bring an acute gouty arthritis. The first group of drugs we're going to talk about are the drugs that block the production of uric acid. So remember, we said uric acid is formed by the action of an enzyme called xanthine oxidase. Xanthine oxidase catalyzes hypoxanthine into xanthine and then xanthine into uric acid. So we have one drug called allopurinol. Allopurinol is an inhibitor of xanthine oxidase. It effectively blocks the formation of uric acid. Usually it's administered orally in the form of tablets. We have two concentration, either 100 milligrams or 300 milligram tablets. This drug is pregnancy category C, so remember this means we can use this drug if the benefits of this drug outweigh the risk of the use. Of course, it would interfere with the synthesis of uric acid in the infants, affecting the purine metabolism, so it can pose some risks to the fetus. The indications for the use of allopurinol: it is used for the management of hyperuricemia of gout, the management of hyperuricemia associated with chemotherapy, and also the prevention of recurrent calcium oxalate kidney stones. The common adverse effects associated with allopurinol: we have diarrhea, nausea, abnormal liver tests. As we said also briefly before, it can stimulate an acute attack of gout. Again, why does this happen? Because after initiation of allopurinol, we're going to have mobilization of urate crystals from their attached sites in the joint to the joint spaces, and this results in acute changes in the serum uric acid level, which can predispose a gout attack. Other side effects include rash. Also, they can cause necrotizing fasciculitis, bone marrow suppression, and very rarely aplastic anemia can occur. Hepatic toxicity and interstitial nephritis have also been reported. Sometimes allergic skin reaction, starting from pruritus or rash into maculopapular lesions, can happen in almost 3% of the patient. Some patients also develop exfoliation of the skin, namely or called exfoliative dermatitis, and in very rare cases, allopurinol can become bound to the lens, resulting in cataracts. Additionally, one serious reaction that can result from the use of allopurinol is called Stevens-Johnson syndrome or epidermal necrolysis, where we have target skin lesions, mucous membrane erosions, and epidermal necrosis with the skin detachment. We said this is very rare and it can happen in less than 2% of the patients. Some patients will develop allopurinol hypersensitivity, which is an extremely serious problem we have to recognize early on. Usually, the first sign is the skin rash. It can develop later on to cause impairment of the renal function, which can also progress to toxic epidermal necrolysis and death. Another drug that's also from the same family, which is kind of a new drug, it has been recently approved by the FDA, is called Febuxostat. It's actually been approved in 2009 for the treatment of gout as being a xanthine oxidase inhibitor. It is structurally different from allopurinol, although it does show the same mechanism of action. It can cause reduction of urate levels of below 6 milligram per deciliter, which is the amount we want or the level we aim for, in about 94% of the patient. It has minimal adverse effects. As compared to allopurinol, it can cause diarrhea, headache, and nausea, but it seems to be more well tolerated in patients who have sensitivity or intolerance to allopurinol. So it is a good alternative to allopurinol in patients who cannot use that drug. Pegloticase is the newest urate-lowering therapy drug. It was approved by the FDA in 2010 for the treatment of refractory chronic gout. What do you mean by refractory? Refractory means it is not responding to other medication. So what is this pegloticase? It is a recombinant mammalian uricase that is covalently attached to methoxypolyethylene glycol or MPEG. What is this enzyme? Remember, we said humans do not possess the enzyme that's necessary for the breakdown of uric acid, which is called uricase, while other mammals have it. So, this drug is actually the recombinant form of the enzyme that's present in pigs or porcine. And by pig, we mean animal here, but the pig in the name comes from the chemical compound, again, polyethylene glycol. And the addition of pig or polyethylene glycol conjugation is to increase the half life of this drug. Also, it helps in diminishing or lowering the immune response for this enzyme that's not coming from a human source, but rather so from an animal source. So we need to decrease the antigenicity of this enzyme or protein in our body. So we do that by the addition of polyethylene glycol. Pegloticase is an intravenously administered drug. It works fast within 24 to 72 hours to reach its peak concentration. Usually, it stays in the body for days, between 6 to 13 days. Usually, the clearance of this drug is by an antibody response. The importance of adding the pegylation or polyethylene glycose is to kind of minimize this antibody response in the body. Adverse effects associated with it include infusion reactions. It can also cause a flare-up of the gout, especially during the first 3 months of treatment. Other side effects include nephrolithiasis, that means kidney stones, arthralgia, muscle pain, muscle spasm, headache, anemia, and nausea. Lots of the frequent side effects include respiratory tract infection, peripheral edema, urinary tract infection, and diarrhea. Now, one concern is the use of this drug in patients with glucose 6-phosphate dehydrogenase deficiency because of the formation of hydrogen peroxidase by the enzyme uricase. Therefore, this drug should be avoided in these patients. Now, another way to control the level of uric acid in the blood is the drugs that enhance the excretion of it. So we have drugs that we term Uricosuric Therapy. Example of them here we have probenecid. Probenecid blocks the tubular reabsorption of uric acid, and it can cause enhancement of uric acid excretion. So this will ultimately lead to increase in the urine levels of uric acid and decrease in the serum levels of uric acid. So these agents are moderately effective. They are mainly used in patients who have tophaceous gout or patients who have frequent gouty attack. While in patients who usually excrete large amounts of uric acid, these agents will not be used. Also, they are not used in patients with renal disease. So their contraindication is patients who have history of nephrolithiasis, kidney stones, patients who have elevated uric acid levels, and an existing renal disease. Also, they are less effective in elderly patients because elderly patients usually have deteriorated kidney function. Side effects associated with them are mild, such as GI irritation. So how do we choose the proper urate lowering drug? We said if we have excessive production of uric acid, in this case we would use a xanthine oxidase inhibitor such as allopurinol. If we have inadequate excretion, in this case we would use a uricosuric agent such as probenecid. So we have a case study here. We have a 55-year-old male who has had pain in his big toe and ankle. So he described 12 hours ago he had pain in my big toe and ankle. So he went to bed last night feeling fine, but then felt as if I had a broken toe this morning. Past medical history, PMH stands for past medical history, of similar problems in the right ankle and in the left wrist. Okay. Upon clinical examination, the patient appears to have acute synovitis in the ankle. Also, the metatarsopharyngeal joints or articulations, they're also inflamed. Remember, these joints are the joints between the metatarsal bones of the foot and the proximal bones. Additionally, the patient presented with acute olecranon bursitis. So, we start the patient on nonsteroidal anti-inflammatory drug therapy. As we said, this is the first line treatment. We can also give the patient steroids at this stage, and this is starting from day 1 to day 10. Usually, before we end up the nonsteroidal anti-inflammatory drugs, we start the patient on a low dose of colchicine as a maintenance therapy to prevent further or any future attacks of this condition. Now we said, what about allopurinol? We said we cannot start allopurinol immediately after an acute attack. So we wait for a period of time while the patient is still on NSAIDs and colchicine, and then we can add allopurinol and we stop NSAIDs after that. So we can add allopurinol as a maintenance therapy to maintain low levels of uric acid in the blood, and then after the attack is subsided, we maintain the patient on colchicine and allopurinol, even though nowadays colchicine is not recommended because of the numerous side effects associated with it. If we have any flare up, we can go again and give the patient NSAIDs at any time during that period. Lastly, just to mention two more groups of drugs, we have interleukin 1 receptor antagonists. Example of these are anakinra, canalcumab, and rilonacept. These are drugs that are used for the treatment of rheumatoid arthritis, and they're also now currently being investigated for the treatment of gout. So what do? They are targeting the interleukin 1 pathway, thus they would suppress the inflammation. So in conditions where we have patient not responding to NSAIDs or colchicine, we would try using these drugs as a treatment. Additionally, not to forget about glucocorticoids, we said we can use glucocorticoids during an acute gouty arthritis attack. One example of these drugs is prednisone. It can be given orally, inside the joint intraarticularly, or subcutaneously, and this depends on the degree of the acute attack, the degree of pain, and the inflammation in the patient. So thank you so much and good luck.